Hello, welcome to another episode of Navigating Cancer Together. If you are new to the show, I am your host, Talaya Dindy. And for those of you who have been listening for a while, no introduction is needed. I am so glad that you have joined me today for another episode. Today, there is a lot of great information coming to you from a retired oncologist. I will get to more of that in a second. Navigating Cancer Together is the show that has something for everyone facing cancer. Why? Because everyone is different with different needs, beliefs, and perspectives. Thank you for joining us for this episode. I encourage you to open your minds and your hearts. Navigating Cancer Together is everywhere. Make sure to subscribe and follow the show to stay updated on our latest episodes. Listen on Spotify, Apple Podcasts, YouTube, or your preferred podcast app or platform. And while you're there, wherever you listen, make sure to subscribe and follow. Today, our very special guest is Dr. Fazlur Rahman. Dr. Fazlur Rahman was born and brought up in what is now Bangladesh. After his medical education in Dakar, New York, and Houston, he practiced cancer medicine for 35 years in San Angelo, Texas. He is an adjunct professor of biology at Angelo State University, a senior trustee of Austin College in Sherman, Texas, and an advisory council member of the Charles E. Cheever Jr. Center for Medical Humanities and Ethics at the University of Texas Health Science Center in San Antonio. His writing has appeared in New York Times, Wall Street Journal, Guardian Weekly, International Herald Tribune, Christian Science Monitor, Newsweek, Harvard Review, Short Story International, Dallas Morning News, and the Houston Chronicle. Dr. Rahman has a lot of extensive writing out there, and it's a lot of great information, a lot of great articles and essays. So if you are looking for information about cancer, cancer care, he is a great resource, and you can find his writings in all of the publications that I've just mentioned. Dr. Rahman, thank you so much for joining us today, and welcome.
Thank you for having me, Talaya. You do a good job.
Oh, thank
Help the
you.
cancer patients, help when they really need it after they're in remission or after the treatment. So I appreciate that.
Oh, thank you, Dr. Rahman. You as well. And we're going to get into more of that later. You are doing a lot of amazing work in your community. Before we really dive into our conversation, I would love for our valued listeners to get to know you a little. Dr. Rahman, what's something interesting or unique about yourself that might surprise the audience?
I think the surprise is that I was born and brought up, it was in Bangladesh, and I was trained in Dhaka, New York, and Houston. And despite that, I kind of settled in an isolated place, a small city at that time. So that might surprise a lot of people and work with a lot of rural patients, cancer patients, where I practiced for 35 years.
Oh, that is a long commitment to taking care of a population that has a lot of struggles. What is something that brings you happiness and joy?
I think that, like what you do, there are not too many things that you can do day in and day out that see the difference in people. So I think that practicing medicine and teaching, which I do now, and writing, these things bring me joy, but mostly because of the interactions with my patients and their families, their loved ones. That probably brought me the biggest joy besides my family.
Wonderful. That's beautiful. And
Thank you.
again, Dr. Rahman, thank you so much for all that you do. We need more oncologists and doctors like you who really invest in their patients. Now, Dr. Rahman, you just mentioned that you were born in Bangladesh.
Yes.
How does your cultural background inform your work in patient care?
I think that two things. One is that, I suffered myself, like a lot of children grew up then. I almost died of cancer when I was only 7, after my mother died when I was 7 too, right after that, few months after that. So that also kind of sticks to your mind. Plus, I've seen so much suffering myself while growing up. And then when I got a chance to do something, you know, those things kept in my mind. Plus, I had some good influence from good mentors, the teachers. And I saw at least one of them what they do, don't do. And so those things actually brought me at least I thought brought me some insights. And that's what I tried to do the best I could. I don't claim that I'm no better or no worse than anyone else. There's a lot of good doctors. I can only tell you what I did.
That's fair. What were some of the do's and don'ts of the mentors that you had?
I think the do's of the mentors was like bedside medicine, because technology, as I was being trained, was enhancing very fast. CAT scan, MRI scan, PET scan, all sorts of things. And some of us, like especially junior faculty, they were just getting carried away with that, as if they are there to understand those things. And they're, of course, taking care of patients through them. But sometimes bedside and patients sort of got sidetracked because of that, so much enamored with technology and all that. And compared to that, some of the teachers that I had, the emphasis the bedside medicine. One of my teachers, Professor Samrov, told me that your healing begins with your empathy for the patients and your reassuring presence at the bedside. So that's what I try to remember. So those things definitely help. And I think that mentors have a lot of influence on the medical students and other trainees. That's why I'm so much for now. That's why my interest is medical humanities and ethics, is that there are teachers, most teachers mean well and they want to teach you good things, but there are enough teachers that will go from patient to patient to patient. And after a while, we kind of lose track and become dulled, versus they kind of give an impression patients are just simply teaching material. Others give the different impression. They said that these people are here for you to take care of them. At the same time, they are giving an opportunity to learn from them. So it's not just their teaching materials. It's not like an X-ray, MRI scan, a PET scan, and all that. But they're people, they're human beings. They came here for treatment, at the same time giving you a chance to learn from them. So that makes a difference if you take that kind of attitude, one versus the other.
I really like that. That's really important. And you said learning starts with empathy. It is something that a lot of us miss sometimes, is that, that's how we're able to connect with other people as well, as being empathetic. And I really believe that empathy is a big part of any form of care.
That's why I got interested in, I know it's a little different, on higher education. I'm a senior trustee, Austin College, which is near Dallas. It's a first-rate liberal arts college. Then also teach medical humanities and ethics in San Angelo State University as an adjunct professor. And also served as a advisory council member for the Shiver Center for Medical Humanities Ethics at the University of Texas San Antonio Medical School, Health Science Center. So I kept up with those things because of my interest, and I think that after retirement, and then of course I went to writing and wrote about myself and my patients. So that's what I wanted to tell you about my second book, Our Connected Lives, Caring for Cancer Patients in Rural Texas. Our Connected Lives, because while I practiced for 35 years, my life was connected with my patients and their loved ones, and their lives are connected to me. And so that is important to me, what I learned from them and what I could do for them, could not do, or what they taught me. Those things are part of the book. Also, the book emphasizes on teaching medical humanities. I believe that empathy can be taught through poetry, literature, arts, and all that. You don't have an expert, but they have an understanding of that to medical students and training. And those things help you to understand empathy. And I give examples like Chekhov's Ward Number 6, if I can mention briefly. This is a very famous short story. Anton Chekhov, Russian writer, is one of the greatest short story writers. And this director of a ward doesn't pay attention to his patients. His patients get abused by orderlies and others, but he doesn't do anything about it. In those days, this happened to be the psychiatric patients. Those days, patients got beaten if they didn't pay attention to it. We have other ways of doing it now, ignoring or hurting. But by the quirk of fate, the same director became the patient in that ward. And as soon as he came in, the orderly started beating him up, pushing him, this and that. Do you know I was the director? I said, no, you're not a director. You're like patient like everybody else. And he actually died of injury, but before he died, he kept thinking, how could I ignore this suffering of my patient for 20 years? How was that possible? And I was here for 20 years and practiced and he took care of them. So when you start with one of those stories to the medical students or pre-med students, it kind of brings the attention, I could have been that patient. So that is the purpose of the humanities in the teaching of science and teaching of medicine in particular.
Thank you for sharing that story, Dr. Rahman. Where can people find your book, Our Connected Lives?
It's in the bookstores, then Texas Tech University Press, but it's Amazon. They put it on sale, so it's a easily available on Amazon, both paperback and hardcover and ebook.
Perfect.
Thank
I
you.
will share a link to your book in the show notes for this episode so that
Appreciate
anyone who's interested can find your book. It's a
it. Thank
very heart centered book. And I really love how you amplify the patients that you've served and shared their different stories because they're all wonderful lessons. So thank you for writing the book.
Thank you so much. I appreciate that. Your comment, all writers like to hear about their books, but I appreciate that.
Yeah, you're
But
welcome.
this is my second book. My first book, if I mention, is called The Temple Road, A Doctor's Journey. That's about my growing up in what is now Bangladesh. And it is the story of my growing up, my learning there, my education, and then my training in New York and Houston, my life in West Texas. The second book is the stories of my patients, Our Connected Lives. And that book will be published here probably within the next 2 years by my publisher as a companion volume to Our Connected Lives. So it's not there yet, and I hope that I'll get to see you then at that time when it comes out.
I'm looking
Thank you.
forward to it. We were just talking about empathy, Dr. Rahman. The work that you do is very emotional work as well. And it's very emotional for the patients also. What are some of the other emotions that you experience on a good day and a bad day that come along with your work?
I think good day and bad day, like I mentioned, they come together. So luckily, one doesn't last too long, the other doesn't last too long, so they rotate. And the good days is that you see somebody in remission, you feel like our definition of cure, after 5 years or 10 years, whatever you decide. The second is that you see their loved one's face and the patient's face, obviously. I know we concentrate on patients because that's our primary concern, but you'd be surprised. And you know yourself, you have been through that. You had Hodgkin's for 14 years ago, and I'm glad you are in remission.
Thank you.
Loved ones affected too. Sometimes it affects the loved one a lot more than the patient himself or herself. So I think that you see the happiness and the relief. Really, that's a big factor. Relief of the patient and their loved ones. So that's a really, really good thing to observe and good thing to see. And the bad days, if you want to call it that, you see it's someone tried so hard, got 6 months of chemotherapy, got all kinds of side effects, the nausea, vomiting. I'm not saying everybody gets the kind of side effects, anorexia, all sorts of things, infection and not. And then you think that they should go into remission, and then they don't. So it's hard to face the patients. Plus, it's hard for the patient and their loved ones because they are hoping for something, didn't happen. And it's not like one of those minor hope or anything. You're trying to survive. Most people really, I'm not saying they're obsessed with survival, but they do it for, I'm sure you probably understand already, they want to do it for themselves and for their loved ones. I have seen patients that older patients, and in West Texas we have a lot of elderly patients. Some of them want to go through the treatments to make their family happy because they want them to try their elderly parents or elderly grandparents or whatever. And you don't treat them just because of that. They have to have other criteria too. But that's one of the reasons some patients will go through all this suffering. And then through all that, after 6 months, 9 months, how chemotherapy goes. It's not like a one-shot deal. You get sometimes, depending on the cancer, weekly, every 2 weeks, monthly, and then maintenance and all that. And after you've gone through all that, and then that person doesn't go into remission, so you can imagine how the patient and the family feel about it. And as a doctor, you can't help, being sometimes discouraged, but then you have to keep up hope. And that's a hope and an important part of care. I'm not talking about falsehood, but you have to have hope. Otherwise, you can give all the medicines in the world. If patient gives up completely, I don't think it will help a whole lot. So hope is an important part of care, and that also comes from, for me as a doctor, as a nurse, how you approach the patients. Sometimes you can give good news in a way that doesn't come out as well as it should. I mean, I'm not saying I'm faultless. I have done my share of mistakes. And sometimes bad news you can deliver in a way that is tolerable, not necessarily acceptable, but tolerable. And the other thing is that especially refractory patients, I mean refractory to treatments, you got to give a feeling that you are going to with them, whether they respond or don't respond. You know, Sometimes we have an attitude is that, you're not responding to anything, so I really don't have anything to do. You can just go back to your primary doctor. I'm a specialist. I don't need to worry about it. But if patient really wants to stay with you, then I think you should give them a chance, regardless whether you're treating with chemotherapy, radiation, or surgery, whatever. So that's another factor that I actually strongly believe. There's certain things that you have to do for the sake of the patient if you can.
I think it's really important for people to remember that oncologists and doctors are human too.
Yes.
And we're all trying to figure this thing out together. So, thank you so much for bringing the human side to the work that you do. You mentioned that sometimes you've made mistakes. What is something that you wish you would have done differently when you were caring for a patient?
I think that one of the main thing that I remember, and I try to be very patient with everyone, but once in a while probably I was a little impatient. We have two competing interests. For example, remember that when I started practice 50 years ago, 1975, complications were very high and we didn't have good disciplined palliative management, pain management or the nausea medicine, this and that, like we have now. And the second is that we didn't have the hospitalist, this and that. So all the practitioners that we had, my colleagues and I were part of a group. So we had to take your own patient, admit to the hospital. When they came to emergency room, and then you may get called on your patient, especially cancer related. You may get called because you are giving chemotherapy and you have the more information immediately than the doctor is on call. Or you have a patient in ICU. So you get competing, you're taking care of a patient in the office, all of a sudden you get a call on ICU, an emergency. So you get a little impatient with the patient that's taking them time. Not only me, so now it's a little bit different. You have hospitalists, this and that, and all sorts of things. They take care of patient in the hospital, you take care of patient in the office. So it's a little different. So those, that is being impatient probably at times. Luckily it was less, much less. And then the second is that I wish that I knew more about the end of life care, because 1975, I may have told you that before, that we didn't talk about much of end-of-life care. Our motto was 50, 60 years in our training is that we have to survive, we have to prolong the patient's life no matter what. After that, we started talking about quality of care. But end-of-life care was an afterthought. We look at the old medical textbook, there was no chapter or anything on end-of-life care. Now there is. So those things, I wish that I had a little bit more training in the end of care. Then obviously after hospice came, it became much easier. But hospice didn't easily pick up in United States. And even though it started in the 60s in England, it took a while here. 1974, the first one, hospice in Connecticut, and then slowly picked it up. Partly because of misunderstanding. You are asking me what I wish I knew. Misunderstanding is that they said patients who go to hospice, they all die. Well, the criteria for hospice is that you have 6 months of life expectancy. Doctors are not God, they could be wrong, but that's the criteria. So obviously these patients unfortunately would have died regardless of hospice. People thought that, oh, all the patients I know went to hospice, they all died. So I don't want to go there. So it took a long time to dispel that misunderstanding. And I was one of the helpers on the hospice of San Angelo in San Angelo. And then I was a voluntary medical director for years. So those things I learned from that, but I wish that I knew those things ahead of time. But partly because of training and partly probably mental said that, I was trained to save lives no matter what. After that, what happens, we don't need to worry about it right now. Now the trainings accept those kind of things, so that's a good thing. And survival, I saw some of your podcast on the survival. That's very, very important. You can't just keep chemotherapy and then patient go into remission and just leave it alone because they have a life and
Mhm.
and they have to navigate through that life.
The evolution of cancer care came to mind. You were mentioning back in the 70s, they didn't have
Mm.
hospice or end of life care, those
Right.
kinds of things. And so I think that's a good thing too, because we can see the evolution,
Yes.
the growth, not just in cancer care, but yourself as well, because being able to adapt to those changes and
Yes.
implement those changes into your care, that's really important also. Dr. Rahman, one thing that I really would like to know is what are some of the barriers that your patients face living in rural areas? I know that the cancer care, the access to different things are a little bit different in rural areas. What are some of the challenges and barriers that your people living in those areas face when it comes to cancer care?
Now things are different. I still a lot of problem. It's different now than say when I started 50 years ago in 1975. One, the rural patients tend to be quite elderly in general. And elderly patients, they get heart trouble, lung trouble, circulation problem, diabetes, arthritis. And on top of that, if you have cancer, that makes it very difficult. So you have to understand that, I'm not saying that young patients doesn't need to be considered. It's not the point. The point is that the elderly patients have a lot more problem versus younger patients. I'm talking medical problems. That's one. And the second is that the distance they have to travel. So if you live in a big city, like in San Angelo, we have, very good care now. So if you have to distance 50, 60 miles, 70 miles in West Texas, like when I started practicing in 75, I was the first oncologist in whole West Texas. And I saw patients from, if you look at the map, Llano to Lubbock, which is probably at least 150 miles, and then Big Bend to Browner, that could be like close to 300 miles. This patient had no place to go, for cancer care. So that's another distance you have to travel. And as you know, chemotherapy patients have difficulty coming back and forth, back and forth, back and forth. So that's one thing. One is that elderly patients have more medical problems, and cancer on top of them make it difficult. Second, you have to adjust certain treatment. But if you want to go, sometimes I couldn't go by the book, and others too, other doctors, because if you try to go by the book, these patients don't get any treatment at all. So you have to adjust that kind of thing. The best is good if the patient can take it or afford it. It's no good if the patient can't take it or can't afford it. And then the third, screening program, this and that. Because of the distances, a lot of them don't want to go, whether mammogram or colonoscopy, something that doesn't bother them, If you're bothered, you have pain, or if you're bleeding, or if you have fever, you're going to go to doctor. But if you're feeling good, that's the purpose of the screening, that you can keep some of the things away if possible. So screening is a big program. And the third or fourth point is that a lot of these people are poorer, patients, and many of them may not have insurance, this and that, and so that's another difficulty they have to fight. So these are some of the problems, like the illness versus distance versus screening versus access to care is a big factor, and specialist care especially very difficult, because and there are good family physicians, all that, but if you need a cardiac care or chemotherapy or cancer care, complicated surgery, you still have to go to a distant place to get it. So those are the barriers. Dozens of medical centers that used to provide care, they are being closed. So a lot of people are going to have more difficult time, because of that again, because of the hospitals being closed, rural hospitals being closed. And then a lot of doctors don't want to go to rural areas, especially specialists. Not so much, first I used to think that because of the money and all that, but that of course is true, but also more so that they feel like we couldn't have resources to take care of patients, so why should we put ourselves through that? But even then, I do feel that the specialists should be available, and they can work in coordination with the others, closest big city where they can help the patients. So it's a big problem, especially in the big rural areas, distant rural areas. Especially places like Texas, Arizona, New Mexico. These places are a lot of distant places. These are big states.
It really sheds light on the importance of making sure that folks living in those areas have access to what they need to care for themselves. You mentioned screening. Well, that's a big part of prevention. And if there's nowhere locally for them to go, as you mentioned, it's not going to be a high priority on their list to say, hey, I should go in and get this mammogram or colonoscopy. I'm fine, so I don't need to worry about it, but you don't really know what's going on inside. So it's so important to get those screenings because you may not have symptoms right away. What are some ways that you have helped your patients work through some of those barriers or even educated or provided resources? What are some ways that you help them overcome some of those barriers?
One was that I tried to do good rapport with the local family physicians, small town family physicians. So I tried to be accessible to those doctors the best I could. That was one way. If the patient couldn't travel 100 miles. And the second way is interesting. We in San Angelo, because let me give an example of radiation that will help us. Radiation treatment is you have to take it daily for 5 days, sometimes 4 weeks, 5 weeks, 6 weeks. So we made a deal with the hotels here, myself and American Cancer Society and Radiation Oncology, that this patient get discount in San Angelo hotels when they stay here, so they can afford to stay. And they could go home on the weekend, they're not getting treatment or holidays. So that's another way we try to help, the radiation oncology, medical oncology, chemotherapy patients. And then third way was some patient who did not have the insurance, we helped them to see if they could qualify for Medicaid. And many did, and some did not, because it's a kind of a irony. I know we're talking about medical care in general. One is that if you have a lot of money, obviously you have nothing to worry, correct? And if you have no money, obviously you have a lot of things to worry, but you qualify for Medicare. But you have a little bit money, you're in trouble because you fall through the cracks. You can't afford it, and at the same time, that's what my patient talks about. The patient really went into remission, but he couldn't afford the drug when he lost the job. It's $104 a tablet at that time, and he had to 1 to 2 tablets a day plus nausea medicine. And he developed acute leukemia and had to have treatment for 3 more years for that acute leukemia. And this patient is already in remission, productive and everything. But he didn't qualify anything else, So that was very difficult. You just try to see if you can get some samples from the drug companies. They make it look like they're trying to help everybody. They really don't. I mean, they have more reason to reject than accept. And I'm not the only one. Others try too. But those are quite difficult. And I'm not saying that one patient is more important than another. But what happens, and I give an example in one of the stories, is that somebody has an incurable cancer, has insurance, and he can treat. And somebody has curable cancer like Hodgkin's disease but doesn't have insurance. What do you do? It's a moral and ethical dilemma too. So you battle through that the best you can. I don't think those things are solved yet, though. I'm not getting into politics, but Affordable Care Act actually helped a lot of people. No question in my mind, in practical thing, regardless what you believe, don't believe in politics, because these patients otherwise wouldn't have get any insurance. And you can say they don't get a real good coverage, but some basic coverage help them a lot. So that helped a lot, but I'm not sure that we're going to have it anymore or not. So those are some of the things you try to do the best you can, whether they can qualify for Medicaid, Affordable Care Act, some kind of assistance from county, or some help from the drug company getting medicines, and then talking to the local people, hotel people, to give them deep discounts while they are on treatment. And some of these hotels are very nice and helpful. So those are the things I did.
Wonderful. Great examples of going above and beyond to help your patients.
Thank you.
It's so interesting because a lot of those problems are still happening today.
Yes.
It may just look a little different, but it's still there. So to that point, Dr. Rahman, where do you see the future of healthcare going? And really cancer care as well?
I wish I had an easy answer. My feeling is that if you want a productive society, democratic society, I know people say, well, a lot of people taking advantage of the system, which is true. Some people are taking advantage. But most people who need help, they genuinely need help. They're not looking for anything. I'm giving an example for a good reason. These patients work. They're not just trying to be lazy or anything, but they don't make enough money. Okay? And if they have a coverage, they can afford only minimum coverage. So it's okay when taking care of simple things, but when they get complicated illness, with deductible, this and that makes it very difficult. So I feel like that as a society, we have a responsibility to people who really need help. You could say some will take advantage, but that whatever that proverb say that you can throw the baby with the bathwater or something like that. So you cannot just, you cannot simply with a one brush say that everybody is taking advantage. No. Those are the people that lose kind of faith in the system. I'm doing my best, I'm trying, and still I'm not getting anywhere. So that's one. I think that as a society you have to decide some kind of, if you don't like the affordable care, something like that, that's one help. The second is that a lot of non-profit hospitals, and this is very unpopular, they are just as cutthroat as the for-profit hospitals. You look at the non-profits, they take only 1 to 2%. There is studies on the 1 to 2% of their revenues for indigent care. Okay, but they make you look like they're taking care of lots of indigent patients. They are not. They're just as much as. I understand that you have to make profit to survive. Money doesn't come from thin air, but excess profit, that's what causes problem. Their CEOs get salary 3, 4, 5 million, 10 million, stock options, this and that. I understand you have to merit. Years ago, I wrote an article for the Houston Chronicle, and I got a flack for that, but a lot of people supported me. At that time, United Health chair was getting like something like $1 billion. It's been quite a few years. So after real protest is yes, he's deserved money because the company made a lot of profit, the stock price went up. I'm telling it because money is involved with medicine. So he said, I'll give $400 million back. So he gave $600 million. So I think there has to be, I'm not saying cap or this and that, there has to be some reasonable amount of compensation. Here you are raising, see your salary billions, millions and millions, and then you're raising the premium. So people can't afford it. You can't blame people for not getting insurance. They can't afford it. They want to get insurance. Tell me, I don't know a single person yet that wants to be without insurance. You may know, but I don't. They can't afford it. And there are a certain number of people that fall through the cracks no matter what you do with the best intentions, doctor, society. They may have a psychological problem, psychiatric problems that they can't help themselves. So that's a different story. So I feel like as a society, we have to decide that some kind of insurance that at least will be available to people to be taken care of. That's one. And the second is that for-profit should be looked into more closely because they don't pay taxes. They save billions of dollars worth of taxes. They get break all over. But if they really get that much break, then also they have to take more responsibility. So that's two. And number three is that a lot of people complain about so-called national health insurance or something like that. But I don't know a single person who want to give up Medicare. I have friends very vocal about government intervention, and I don't like intervention much either. I have to go through that, deal with. But certain things are necessary for the sake of the society and the country as a whole and for the people. So I don't know anybody, even the vocal opponents of government, and nobody wants to give up the Medicare. Why? And these people are well up. We have a dichotomy in our character that most of us do, and sometimes good and bad come with the mix. Would it solve the problem, Medicare for everyone? I don't know, but that's something to be looked into. So non-profits, then the abuse by the hospital systems. And, I know one company here in Texas, for example, they have hospital, they have insurance, they have middleman distribution of drugs, they have pharmacy. Okay. So once you become their customer, you're kind of beholden. They have no choice or anything like that. I think that is quite detrimental for the country and detrimental for the healthcare as well. There shouldn't be too much of monopoly on anything because there is no competition or anything. A lot of hospitals getting closed because of that. I'm not saying that you don't make profit, you have to. One time I wrote a letter in the New England Journal of Medicine about that in response to an article there. Some big expert wrote that the hospital chain should be big so they will be there. They can be more efficient. It didn't work out that way. An example, HCA, Hospital Corporation in America, they got into so much trouble that finally federal government had forced them to break up into different units. Okay, so it doesn't work if you make a monopoly in a city or anywhere. So those things I think should be avoided, and those should be prevented. That in a city there are two hospitals, they should be allowed to survive both of them. So in any number of things we have to do, not just one or the other. But we have to change our heart too. That's the point. If you think it's somebody else's problem, it's really not, because people who come to emergency room, they cost a lot of money. And where does money come from? From taxpayers, you and me. So we are already paying for it. So why not pay in another way, just more efficient, less suffering, more productive, and less expensive?
I appreciate you just being so vulnerable and forthright about your viewpoint and where you see things going, because that's an important part of advocating for yourself, is having a little bit of knowledge about some of these things that are going on, because they are steering the direction of how healthcare is given and performed and who gets it and who doesn't.
Correct.
So thank you for sharing that, Dr. Rahman. All great points.
It doesn't always make me popular, though.
Yeah.
I'm not a crusader or anything, but I say what I see. So,
Yeah.
and I've written about these things too, for big papers. Some of the things: New York Times, Wall Street Journal, Newsweek, Guardian Weekly, London, Lancet magazine. Some of the personal races, then Harvard Review and all that. So it's not like some of my, especially cost of care. My book talks about that. Cost of cancer drugs and all that. It's artificially high sometimes.
Yeah, that's a conversation we could talk about for a long time,
Sure,
because,
sure.
it is really unfortunate. I remember when I was going through treatment, this was in 2011, and I believe one chemo infusion at that time was over $2,000 then. So, yes, I can imagine how much it is now. And people are losing their homes, they're
Yes,
losing everything
yes.
to get the treatment that they need and deserve.
And again, I know it's becoming like a slogan, but it's not. That if we are the richest country in the world, then I feel like our first responsibility is to the people. They are the country. I believe in capitalist system. I believe in that free market and all that I do. But I certainly don't believe in excess. No.
Yeah. Yeah, there's a difference. Dr. Rahman, you have cared for so many people with cancer. What does navigating cancer together mean to you?
I think first I mentioned to you first that one is that patient have to have a feeling from the doctors and nurses, especially from doctors since they are in charge, that you're going to be with them, whether in remission or not remission, you're going to be with them. Okay? And that gives a lot of reassurance. So that's navigating one. Second, when patients go into remission, we feel happy and then intend to forget the patient that that patient's in remission. I got too much problem right now. But patients who are in remission, we have to navigate with them as well, because a lot of them reassurance. I had patients that were in remission wanted to see me. I saw them once a year, not because I'm any better doctor or any other. It's simply they wanted to see me. It's okay. Once a year, reassure them, check them, whatever you can. So that definitely helps them. And then once we become very close to patients, and that can have goes both ways, can be time consuming. So that's what I was telling, that I wish that sometime I wasn't impatient, is that they bring your personal problem to you because they have this, or they're feeling this, or they're feeling that, may not have anything to do with cancer. So that's why it's so important to understand the patient. The patient may have a heart trouble, patient may have a diabetes problem, this problem, that problem. So I always, at least I'm sure my colleagues did the same thing, that is, once they're in remission, said don't just get honed on the cancer alone. Take care of your diabetes, take care of your heart problem, take care of your arthritis, take care of your other problems, diet, exercise. You don't have to champion or anything, staying active and everything, staying positive. And we have to reinforce that periodically, because I've had patients that good remission 4, 5, 6 years, and all of a sudden something they have nothing to do with cancer. I think my cancer has come back, and they get panicky, and you have to take time to explain. I'm checking it, everything is right, and that helps them a lot. So they're also navigating with cancer. But you got to think about I know one of your programs talking about holistic care. I know that's a really fancy term, but that's really what it means, that you have to diet, exercise, positive attitude, staying connected. Those things definitely are necessary to navigate cancer. It's not just medicine and doctor. It has to be other things as well. And then you also have to have some kind of rapport with the family members. That is, hopefully, that family members sometimes help too. Sometimes friends are more helpful than family. You'd be surprised. Because I've seen in some cases families have their interest. Okay, I don't like my dad because my dad this and that, or my dad favored my sister and my other brother. I've heard that too. I'm sure you have.
Mm-hmm.
But a friend would be different. He has no interest. He's not interested in your property or money or anything. Friends, because you have been friends, are trying to help you. So sometimes friends are a lot more helpful too. I always told my patients, bring someone, family member. And pretty soon I learned that some people don't want to bring family member. Occasional patients, bring someone you trust, a friend or whoever, and they will. And you tell them too that, he's going to have his ups and downs, she's going to have her ups and downs, so you can help her out or help him out. And they will if they can. So that's also navigating cancer. It's a whole person, and whatever else disease they have to take care of everything, screening and all that. Not simply cancer screening. If you have the colonoscopy, you have colonoscopy. If you have to mammogram, you have mammogram. And routine, when necessary. Unnecessary screening has its side effects too. Those are some of the things you have to do navigating cancer. And also finding like-minded people, it helps a lot. There are people, and you know a lot more than I do, you deal with so many other interviews, is that some people can make you feel good even in a dire circumstances. And some people can really make you depressed even in a good circumstances.
Yeah.
So so you have to, even in regular life too.
Mhm.
So you have to pick, feel comfortable in. You have to find like-minded people. That is, not everyone is going to be perfect. That's how we're made up. God made us that way, I suppose. So if like-minded people, that definitely helps with navigating cancer.
Yeah, I agree with all of that. You were bringing up a lot of different things about life. Cancer does not happen in a vacuum. Although someone's diagnosed with cancer, life is still going. Things are still happening in their life. And so trying to work through cancer and all of those things that they were probably trying to work through before is a lot. So cancer does not happen in a vacuum. Life doesn't stop because someone is diagnosed with cancer.
Correct. For example, a person supposed to live only 2 years, live 23 years, the first patient. So you have to remember that when you think about cancer, that is prognosis is not written in stone. Because each cancer patient, same cancer will be different. Biologically, every human being is different. Certain basic things are the same. So if you have 5 breast cancer patients, they have 5 different outcomes. And just because somebody got sick or something doesn't mean it has to happen to you. The second one, we don't have that now, but since it came up in the past, especially 50, 60 years ago and more before that also, they didn't tell women they had breast cancer. They would tell their husbands or sons or men. They think that they couldn't handle it. So they wouldn't tell the women. I've been seen in my training, Rachel Carson, who wrote The Silent Spring, is an example. She had breast cancer and her surgeon didn't tell her. And according to the New York Times, her story is that surgeon outright lied to her that you don't have cancer. But she died of her breast cancer 4 years later. Now, of course, Rachel Carson was one of the smartest women you can think of. I've seen in my training too in Houston and New York. If you are especially for a minority, Hispanic or Black, whatever others, sometimes you are not taken seriously, like your cancer is not as important as somebody else's cancer. At that time, it took me a while to kind of get adjusted to it and but worries about my training sometimes. Then after a while, after 2, 3 years, it becomes a kind of normal to you too. And that is very, very dangerous. That's why I said that mentors had a lot to do with it and how you train the doctors, medical students, and all that. You have to take everybody seriously. And then the third one, we're talking about the patient that went into remission, then relapsed because couldn't afford the drug, lost job. And it shouldn't be that way. The fourth one was the 87-year-old patient. That talks about the elderly patient because 85 plus years is the fastest growing population in the country. So we're going to have more and more cancer. So we have to decide now how much to do, how much not to do. And cancer treatment is decided not so much because of the age. Numerical age doesn't mean anything. A person I've seen, the farmers, cancer, they hurt people, 75, 18, still very active. And then someone 45-year-old, a drug problem, alcohol problem, can't tolerate treatment. So quality of life and the functional result is important. And then the last person talks about the dignity that, I deserve dignity too. We all deserve dignity. I bring up this thing. It's part of the cancer care and part of also the navigating cancer.
Yes. As we wind down, Dr. Rahman, as we get towards the end of our conversation, I think this question that I have is so important because it's about the future. And we have all of these technological advances in medicine today. What is one piece of advice that you would give to a new oncologist or medical professional who is just starting their career? And in terms of prioritizing the humanistic side of medicine, what is one piece of advice that you would give to them?
Well, thank you. That thing is very, very important question. I tell students that bedside medicine is still most important thing. You are taking care of a human being. CAT scan, MRI scan, PET scan, and all these tests are important to diagnose and follow cancer. But they don't supersede your bedside judgment. Because patients really don't, obviously they worry about the report, but they worry about what you tell them and not to tell them, what news you give them, don't give them. The second reason is so important to your question is because we are getting into AI now. And what worries me is that, and now you can say that an older doctor is going to give this advice, is that AI and all that. So patients now get a lot of training from robots and from models. So you should do all those things. And then you see all these scans and x-rays, already spend time. And then AI comes in the middle. Hopefully it will help. But what worries me is that doctors will get all technology centered and patient will be secondary consideration. So bedside medicine is still very important. I can tell you personally, I've seen, and then my friends and my patients also tell me I'm retired. I still know a lot of people. A doctor talking to you and then typing, so not paying full attention because he wants to keep up with what you say. And now, of course, he can apparently, type with AI and all that. So again, bedside medicine and direct patient contact, and the same thing that my mentor told that Patient's healing begins with your empathetic attitude towards the patient and your reassuring attitude at the bedside. That would be my observation and advice if that's worth anything.
It certainly is. Thank you so much, Dr. Rahman. This was really an insightful conversation. And I just love how you have woven so many things into your career and how you are giving back to other people by teaching and helping them to develop a good bedside manner so that more cancer patients and their families are receiving person-centered and holistic care that they need and deserve. Before we wrap up, is there anything else that you'd like to share?
I appreciate it. First, I would like to thank you for doing the program you do, because navigate cancer together is the right word. You cannot navigate alone, no matter how strong you are. Keep up with the good work you do.
Tell people where they can find you. What is your website?
Oh, my website is fazlurrahmanmd.com.
I will share all of that information in the show notes. Thank you again, Dr. Rahman, for sharing so much of your wisdom and for your time today.
Thank you so much for having me. I really mean it, okay? Thank you so much. I appreciate that, and I hope that you are completely cured, okay?
Thank you.
You are. It's 14 years is a long time. You're going to make another 70 years.
Dr. Rahman, thank you for your time and for sharing your important stories and insights. Valued listeners, please let us know what you think about this episode. You can leave a comment on Spotify. You can also leave a comment on social media platforms using the hashtag Navigating Cancer Together. I would love to know what you think about the information that Dr. Rahman has shared with us today. I must give a shout out to a very kind sponsor. Her name is Paula Detjen. I want to thank Paula for sponsoring this episode of Navigating Cancer Together. Before we end, I would like to give a shout out to the Navigating Cancer Together community and valued listeners. Thank you for joining us. That is it for this Wednesday. And until next time, let's keep navigating cancer together. Take care.